So good morning. Today we will discuss about intraoral radiographic techniques. Intraoral techniques, it shows the individual teeth and the tissues around the apices. It shows 2 to 4 teeth and the surrounding alveolar bone where we can use conventional films or digital sensors. The tooth and film should be in contact as close as possible, and both the tooth and the film place should be parallel to each other, and the long axis of the film should be vertically placed for anteriors, that is incisors and canines, and horizontally for premolars or molars, that's the posteriors. And the X-ray beam should be at right angles to the tooth and film, and the positioning should be reproducible. Intraoral radiographic techniques mainly, the most common is a periapical radiography, which consists of paralleling and bisecting angle technique, occlusal radiography, bite-wing radiography, and localization techniques. Now, the accessories we use while we go for a film holders, which are devices used to position film in mouth and retain it in position. And the three basic components are mechanism for holding the film parallel to the teeth that also prevents the bending of the film. Then there is a bite block and an X-ray beam aiming device. The basic principle in any projection geometry is that the focal spot or the source of radiation should be as small as possible. The focal spot and the object, here the object is a teeth, the distance should be as long as possible. The object and film distance should be as small as possible. The long axis of the object and the film should be parallel to each other, and the X-ray beam should strike the object and film at right angles, and there should be no movement of the tube head, film, or patient during exposure. Indications of periapical radiography, the most common indication is detection of the periapical region or any infection or inflammation related to the periapical region, assessment of the periodontal status, the unerupted teeth, root morphology before extractions, after trauma, endodontic procedures, pre-op assessment and post-op in case of apical surgeries, evaluation of the periapical cyst and other lesions, and evaluation of the implants. Coming to the first technique of periapical radiography, that is a paralleling technique. The synonym is right angle technique or a long cone technique. Here we place a film parallel to the long axis of the teeth, and the central ray is right angle to the teeth and film. There is a long object film distance because of this maintaining parallelism, and a long target to film distance. The position indicating devices are used in paralleling technique, which holds a film parallel to the tooth, which consists of a already discussed bite block and an X-ray beam aiming device. The 5 basic rules in all film taking is, first is the film placement should cover the prescribed area of the teeth. The film should be positioned parallel to the long axis of the tooth, and there is a vertical angulation where the central X-ray beam should be perpendicular to the film and long axis of the tooth, and horizontal angulation means the central ray should be directed through the contact areas of the tooth, and the film exposure, that is the central ray, directed to the center of the film. Periapical radiography, the advantages and disadvantages of paralleling technique. Advantages, it's a dimensional accuracy, there is minimal distortion, the simplicity in technique, and we can duplicate the tooth as such in a film. The periapical region is correctly seen, and the bone levels are also well represented in the film. Whereas the disadvantages, again, the film placement, it is quite technique sensitive. There is some patient discomfort. Exposure time is more. The third molar region, such parts are very difficult to get, and sterilization, because we are using some film accessories, it all have to get sterilized. Coming to the vertical angulation, vertical angles are only approximate. Each positioning should be assessed independently. Vertical angulation suggested should be taken only as a general guide. Horizontal angulation means the central ray is aimed through the interproximal contact areas to avoid any overlapping. Coming to the second most common technique in periapical radiography, that is a bisecting angle technique. Here we follow the Siesenski's rule of isometry. The rule suggests that two triangles are equal if they have two equal angles and share a common side. The synonyms are short cone technique. Here the film and the long axis of the tooth when we place forms an angle. And imagine that there is a bisecting line that divides its angle into two. And now the film, the central ray should be perpendicular to this imaginary bisector. And there is a short object film distance and a short target film distance. Guidelines: the wide side always faces the teeth. Anteriorly, the film is placed vertically and the posteriorly it is horizontally placed. The occlusal door should be towards the occlusal plane and the film should cover the R area of interest. The patient should be positioned. Before taking, the patient should be explained about the procedure. The head position should be stable and remove all type of foreign objects, dentures, retainers, and the glasses. The head position, the occlusal plane should be parallel to the floor and the sagittal plane should be perpendicular to the floor. The alar tragal plane should be parallel to the floor. Head tilted little backwards and mouth in open position. The occlusal plane of mandible parallel to the floor and corner of mouth to tragus parallel to the floor. Film placement. Usually in bisecting technique, the patient's fingers are used to stabilize the film and film holders are even there. Horizontal angulation, the central rays through the contact points of the teeth. Point of entry, the X-ray beam through the center of area to be radiographed. The vertical angulation, if it is getting increased, it will result in the foreshortening of the resultant image. And if the vertical angulation is decreased, it will lead to elongation of the resultant image. Horizontal angulation should through the interproximal area to avoid any overlapping or through the contact areas. In the bisecting technique, the exposure, while giving the exposure, the film should be as close as to the tooth without any bending. Now there is an angle formed between the long axis of the tooth and the long axis of the film. And imagine that there is an imaginary line that bisects this angle into two, and the central ray should be at right angle to this bisecting line. The advantages of bisecting angle technique are its position is very simple and easy, may be used even without film holders. The image same as tooth only if we are giving the proper angulations, and because we are not using any type of film holders, there requires no sterilization. Disadvantages: there is no correct representation of the tooth in the image, resulting in image distortion. The incorrect chances of incorrect vertical and horizontal angulation, and while the patient is pressing with the fingers, there are chances of film bending, unnecessary radiation exposure to patient's finger, periodontal bone levels are poorly represented, the shadows of zygomatic bone usually overlaps the molar roots, foreshortening of the buccal roots, premolars and molars, chances of concut, and as a result, we are not able to produce a reproducible view. Comparison between long cone and short cone technique. Long cone technique, also called paneling technique, and short cone technique, also known as bisecting angle technique. Long cone technique, sharp details or images we get, whereas in short cone there is distortion. In long cone technique, the image same size and shape of the object, but in short cone, if the vertical angulation and the horizontal angulation is not proper, it will lead to elongation and foreshortening and overlapping. The images of tooth are anatomically accurate in long cone technique, whereas images of teeth are distorted in short cone technique. Alveolar crest is true in relation to teeth in long cone technique, whereas in short cone, the shadow of alveolar bone fill the interproximal areas. There is less vertical angulation in long cone technique, more of vertical angulation in short cone technique. In long cone technique, there is always zygomatic arch. Shadows are not usually seen. But in short cone technique, always a superimposition of shadows of zygomatic arch and teeth. Long cone technique, because we are using so much of accessories, we lead large working area, whereas short cone is an easy technique and less working space. In long cone technique, the shallow palate teeth, the apices are usually cut off. Whereas in short con technique, it is a more effective way where we are getting in shallow palatal arch, but some modification should be made. In long con technique, there is PID to reduce the con cut, but in short con technique, con cut is always an faulty radiograph. Long con technique, the film holding devices avoids curvature of the film, whereas in short con technique, the curved film, there will be chances of film curving due to the finger pressure. Thank you.